Rami, I want to come back to something. We were talking about the diagnostic criteria, and I don't remember Mary Frances talking about next-gen panels looking at all these markers. Now, based on some of these new prognostic models, do you think we should be getting next-gen panels looking for ASXL1 and EZH2 mutations and so on?
Right. So they are not part of the diagnostic criteria. Obviously, a clonal marker, the JAK2 mutation or the caroticulin or the MEPL are part now of the diagnostic criteria. But I do think they have value to be checked, definitely from prognostic value, and maybe down the road could become important from a therapeutic value. So definitely we know in myelofibrosis, presence of SXL1 or SRSF2 mutation is associated with worse outcome. There are other mutations that are labeled as higher risk mutations. Some mutations may predict the response to treatment. Even with ruxolitinib, there had been, look at patients that have higher risk mutations versus not. So I think it's valuable to check for them, but they are definitely not part of the diagnostic criteria yet.
Okay. Mary Frances, I'm going to have Ruben go through the data of Ruxolitinib for myelofibrosis in the COMFORT-1 or COMFORT-2. But before he gets there, I want to put you on the spot. It seems to me from those studies, very positive studies, it calls into question, is there room for any other initial therapies other than Ruxolitinib in myelofibrosis, or is that really your go-to based on the data?
I think at the moment it has to be the go-to based on the data. Apart from anything else, it's the licensed therapy. I work in the part of the world where it took quite a long time, where we were behind actually getting access to it. So it was interesting watching that where suddenly a therapy became available. You wanted to give it to everybody. It almost seemed as if there were more people with myelofibrosis, but really that was because there's something you can do, so therefore everybody picks up the patients and refers them to you. So I think in the absence of something better where you could do an upfront clinical trial, and I think that's probably unlikely to happen, it has to be the starting point at the moment.
So Ruben, why don't you go through the clinical data that has convinced all of us of this?
Sure. Well, so the COMFORT studies were the first large randomized phase 3 trials done in myelofibrosis of any agent. And now over 8 years ago, both of these studies have really been highly impactful. They were Ruxolitinib versus placebo, the COMFORT-1 study that was a North American and Australia study, and COMFORT-2, which was done in Europe versus best alternative therapy. They combined clearly showed several things. One, Ruxolitinib was clearly superior to either placebo or best alternative therapy. It didn't really matter what else you chose to use for control of splenomegaly in an under a 6-month time frame, so relatively rapid response, and significant improvement in the disease-associated symptoms. Again, both in a placebo-controlled way as well as with best alternative therapy. What we've learned over time is that the consequence of improving splenomegaly in symptoms was very impactful. Both in terms of that short-term benefit that you feel. The patient's clearly feeling better, they're better under control, but clearly a longer-term piece. We've had analysis which have showed that with the combined data set as well as individually, when one accounts for the issue of crossover, there is a survival advantage. Now that was not pre-built into the study, so there's always been controversy and discussion around this. But I'd say unequivocally with the clinical experience that I've had with these patients, there is zero doubt that there is a clear improvement in survival as a group. Tougher to say at an individual patient level, and that has become very clear. And now, how can we say that? Well, one is we look at the data, without question, even accounting for the crossover, there's clearly an improvement in survival. Now, there's not a plateau. It is not a cure, but it clearly improves survival. We know there are individuals that remain on Ruxolitinib who even started on the phase 1 studies that we started at Mayo Clinic and at MD Anderson back in 2007. There are patients who are now on the drug for 12 years who had a life expectancy of under 3 years when the trials started. I've had patients who have been on ever since the drug became commercially available, who long ago should have passed away from the disease. So the sheer rate of patients who are passing away from myelofibrosis has clearly decreased, and it's clearly from ruxolitinib. Now, why is that the case? Tough for us to know for certain, but there are certainly several theories. One, clearly less debilitation, but it probably must be even more than that given the length, but that certainly is a factor. Two, potential less progression toward acute leukemia. Again, very difficult to prove without a bulletproof control arm, but the rates certainly seem to be lower than they had been kind of in the pre-Rux world. Is there a benefit by a decrease in the inflammatory milieu in the bone marrow? In other words, it's improving cytokines, but maybe that makes a big difference. You have a toxic bone marrow microenvironment. Maybe that leads to additional genetic mutations and a greater likelihood of disease progression. So I'd say it's been a big impact. It clearly still leaves us room to grow, because as one looks at those curves, there's not a plateau, so there's not a cure that is involved, but it's been highly impactful, and the data have really rung true in that every parallel study that's been done afterward, open label study, individual country experience, all have found that those data are accurate.
Even if you're not convinced by the symptom control and control of splenomegaly, which were the primary endpoints of the study, what I find fascinating is survival's easy to measure, right? I mean, you're either dead or alive, okay? And what was interesting about the survival curves in both Comfort 1 and Comfort 2 is they actually didn't start to diverge until after the median from when patients actually crossed over. And for me, that suggests that it supports what Mary Frances said, that this really should be in a symptomatic patient, in an intermediate 1 and high risk or high risk, intermediate high risk patient, that you really need to start with your best agent to see that benefit. Would you agree with that, or?
I think so. I think there is no scientific rationale for using it as a salvage therapy. I think things that we have learned is that salvage therapy type approach in MF, whether it's waiting for people to get really sick to start ruxolitinib, they're likely to respond, but they're going to respond less. Likewise with transplant, if you wait for patients to get really sick, their outcomes with transplant are worse. Myelofibrosis is not a disease to wait to initiate therapy. I think starting therapy earlier, whatever that is, probably is highly impactful.